Getting a diagnosis of depression is not always a very straightforward process. Sometimes it takes time to make that diagnosis accurately. And the reason why it takes time is because depression has been associated with so many factors. For example, you have to ensure that this depressive episode that the patient is presenting with is not associated with another medical condition, such as hypothyroidism, such as heart failure, such as chronic kidney disease, or someone going through dialysis, such as cancer, because all of these chronic illnesses can predispose a person to depression. You have to also ensure that this patient is not using medication and the depressive episode is a side effect of the use of that prescribed medication. For example, if a patient is epileptic, that means that their whole life they're probably going to be using anticonvulsants to treat their epilepsy. And the long-term use of anticonvulsants predisposes that person to depressive episodes. So the management, the way that you're going to approach these different patients is going to be very different because their needs are different. The other one is to ensure that there's no substance use like cannabis, like heroin, like, for example, alcohol. Yeah, all these can predispose a person to a depressive episode. And so even the approach of management is going to differ. Now, this assessment is going to require that you evaluate for these factors. And once all these factors have been ruled out, then you can come to the diagnosis of major depressive disorder, which we commonly call depression or label as depression. Now, after you've made your accurate diagnosis of depression, you come to formulate your treatment. How are you going to approach it? And so depending on the severity, depending on chronicity, depending on other factors, you might either go with psychotherapy, let's say CBT, interpersonal therapy, or you might go the medical treatment way. So if you go into medical treatment, that means prescribing medication. And usually the first medication that we prescribe is called an SSRI. It's an antidepressant. In our setting, we have fluoxetine as a common antidepressant, and there are many others, of course. So when you're prescribing that medication, it's very important to help the patient build realistic expectations about the effect of this medication that you're prescribing. And the realistic expectation is that from many studies we see is that we expect that there's going to be a delay in experiencing the effect of that medication between 2 weeks to 4 weeks. And a lot of people are not motivated to wait that long, are not motivated to be patient to wait for that effect. And so they would usually come after the first week and say that the medication is not working. And it's not advisable to change the medication within the first 2 weeks. It's also not advisable to wait too long, past the 4 weeks or past the 8 weeks, to prescribe another antidepressant. So the first treatment is a single antidepressant. Give it 2 to 4 weeks, then review. Is it working? Is the patient experiencing any side effects of using the antidepressant? What is the impact? And then if it's working, you continue on the antidepressant. If it's not working, you may go on to try another antidepressant. When you delay switching the medication, especially if it's not working, that is usually a bigger risk factor for the person developing what we call treatment-resistant depression, such that when you delay prescribing, then you reduce the chance of introducing another antidepressant and getting any effect. Actually, it reduces the effect to up to 30%, meaning if I put you on another antidepressant after delaying to switch you on the first one, then you have only a 30% chance of that antidepressant working. And so depression is quite complicated and also simple sometimes. And it's important to approach it from an individual to individual patient for you to get an accurate diagnosis and get an effective treatment for that diagnosis.